Thank you for joining us. I'm Raquel Faria, an internal medicine specialist at Centro Hospitalar Universitário de Santo António in Porto. Today, I'm honored to host Professors David Isenberg and Ronald van Vollenhoven from the Lupus Academy Steering Committee. Together, we'll explore groundbreaking lupus research presented at the major congress in 2024. Let's dive into these transformative advances shaping the future of lupus everywhere. So, David and Ronald, welcome and thank you so much for joining us today. Ronald, let's just begin with your opinion. What do you think that in a global way was the most relevant work in lupus in 2024?
Oh, saying what the most relevant work was is really difficult because 2024 was quite an exceptional year for lupus researchers, especially for those who are in clinical research and looking at clinical therapeutics. And I must say it's been quite spectacular because so many drugs reported out either positive trial results or in abstract form, maybe initial results. And there were lots of very promising data coming through at international congresses and in the literature. And it's almost impossible to go through it without forgetting or omitting one of them, but I'm just saying dapirolizumab, ianalumab, obinutuzumab, deucravacitinib, upadacitinib, telitacicept, daratumumab, and the list is unbelievable. And it all looks promising and good, but of course there are very, very specific, interesting things about all of those drugs. And there is an additional development, which is probably if you press me against the wall and you say, well, what's the one thing that stood out? I think for most people, it would be the report of CAR T cells in autoimmune diseases, including systemic lupus erythematosus in an uncontrolled and rather small pilot study that nonetheless was reported in the New England Journal of Medicine in this past year. I think we can't get around the fact that that was an absolute highlight for lupus.
Thank you, David. I know you are excited about this. So for you, 2024, generally, what was the relevant work?
Okay, so I am in general terms an optimist, as Raquel I think knows very well, and Ron too. But I think although this past year has had the capacity to be a sort of annus mirabilis, I think it's very important to remember what we have learned the hard way, the bitter way really, which is the number of successes at phase 2 that were followed by failures at phase 3. And many of the drugs that Ron has referred to were mainly, not exclusively, but a lot of them were phase 2 trials. So we know, for example, that ebrituximab, baricitinib, secukinumab, which Ron actually had a lot to do with, and the peptide regerimab all looked great in phase 2, failed in phase 3. So I think that my excitement is genuine, but is tempered by that knowledge. Somebody worked out that there have been something like 30 failed lupus trials in the last sort of 5 to 10 years. So I think, yes, exciting. I'm just a little bit more cautious, perhaps. But the CAR T cell idea is really intriguing. I try to avoid what I call the C word, the cure word. But what is dangled in front of us by Georg Schett and his colleagues is cure, because here were patients with very aggressive disease. After 3 months, they'd stopped all their lupus treatments, and in the patient who's followed up for the longest, 4 years, I think, has gone now with no lupus treatments and no antibodies in the serum. That's pretty amazing, actually. That really is amazing. So those were the things which excited me, but with that note of caution.
Thank you. So let's start with that. The new therapies that have gone successfully in trials, and we can discuss it all together and then a little bit about one and more. The first thing is most of them, the trials were for systemic lupus erythematosus and some of them to lupus nephritis particularly. And I would mention firstly the phase 3 trial that was successful, the dapirolizumab pegol. And then some of the phase 2 trials with deucravacitinib, ianalumab, daratumumab, and not quite easier, but already behind and promising telitacicept. What do you have to say about that also? So can we start with you, Ronald?
Yes, thank you. And of course, I first and foremost have to agree with David that we need to be cautious and not get overexcited when we see positive results. But I do have to also add that some of the phase 2 trials that have now reported out positive results were actually very large trials, equally large to phase 3 trials many years ago. So, and they were very well done. I think that we can be we can be optimistic. I like to think that this is going to lead us somewhere. But what we are also thinking is, okay, if we see these positive results, but we already have some drugs for lupus, and we know that the drugs that we use today, which includes, of course, conventional drugs and 2 approved biologicals, and even there are some off-label use for some biologicals. And then we know that the results using all these drugs, yes, they do work, but we don't achieve the results for our patients that we so much would like to see. So are all these new drugs going to make it possible to achieve this for more patients? Or is it just that we will see the same thing? And then that's why I'm hoping that we can really also have a great deal of happiness from the fact that many of these drugs also work with different mechanisms. Because I do think that probably for each patient, the best mechanism is not the same. So indeed, the approved biologicals, belimumab targeting B cells, but by downregulating, not by depleting, and imvotamab targeting interferon. Those are very different mechanisms, and so that would have to be for probably different patients. And then now we're seeing mechanisms that are yet again very different. The inhibition of the JAK-STAT system that includes TYK2 with deucravacitinib and also JAK1 mostly with upadacitinib. It does include also the B cell targeting again, but now with depleting agents, obinutuzumab and ianalumab. And it also includes a very interesting mechanism through the co-stimulatory signal CD40-CD ligand. And you already mentioned the name, Raquel, of this drug, and it's so difficult, dapirolizumab pegol. They really need to come up with a better name. But that had actually a phase 3 trial, so a really big trial, and it was successful, very recently presented. That is going to have to be replicated in a second phase 3 trial, of course, and I believe that is now underway, or at least it's being planned very intensively. But then that is a very different mechanism. So hopefully also having not just different drugs, but having different mechanisms will allow us to treat more patients effectively and bring them in remission or a very good state of disease control.
David.
So may I tell you a short story which might amuse you if you don't know it? So the story of dapirolizumab is quite remarkable. It goes back 26 years, actually. I think it was 1999. I'm sorry, Ron will have to remember he was there, but I was called with about 50 or 60 other investigators to a fabulous, a meeting at a fabulous hotel, I should say, in Vienna, where, if you like, DAPI Part 1 or version 1 was sold to us in a very hard way for 2 days. We were told this is great, very important agent because it blocks CD40 ligand. Nothing like this has been done before. Very exciting, very thrilling. And then for the last sort of day or so, we were told, Isenberg going to conduct the trial. If the patient comes in on a Wednesday morning, it's the blue tube. If it's a Thursday morning, it's the green tube. Huge detail. And then on the morning of the 3rd day, a very remarkable thing happened. In fact, I've never seen anything like this in my professional career. The guy who was organizing the trial was a lovely guy from the UK called Akshay Vaishnav. And Akshay walked into this crowded room and he went to the podium and he said, "Ladies and gentlemen, I'm afraid I have to tell you that I was told last night that a patient in Belgium, given this drug, has had a stroke. And I've become aware that a patient in another part of Europe has had a heart attack. And therefore, we have decided to cancel the trial. Oh, and by the way, my wife in Boston is not very well. I have to leave now." And he walked out. He just walked out. And it was like the waters parting. And he just walked out, leaving behind about 12 colleagues who were as in the dark as the rest of us. And you could feel the jaws dropping all around the room. We just couldn't believe what had happened. He just vanished. And we all assumed that the drug was going to disappear forever. But it was very interesting. And I have to say fair play to the company. They took this to heart, and they tried to look very hard at what exactly was the cause of this increased clotting problem. They concluded that it was the FC portion which was the problem. So they figured, well, if we could replace that with something more inert, such as a PEG or whatever, then the FAB should still work, and that's exactly what's happened. So what we see now, DAPI 2, if you like, is an upgraded, better, safer version of a drug which became available 26 years ago. So it's an amazing story. And I have to say, the company took it very seriously, and colleagues from the company worked very hard to make sure they got good centers involved, good training was brought about. It was very interesting, and it looked very successful. So that was great. But what was amazing was that the success of this trial was announced in the same week as the obinutuzumab trial which is lupus nephritis, of course. So for the first time ever, and possibly it'll never happen again, we had 2 phase 3 clinical trials in lupus successful. It's a miracle.
David, and so this dapirolizumab pegol, it's a different physiopathological way of changing lupus, quite different from BAFF or depleting B cells or interferon. Do you have any idea in what kind of patients would you think this could be a first choice, if available, when available?
Okay, so that of course is a very key question, but is also an unanswerable question at the moment, because in the end, pharma companies end up doing 2 kinds of clinical trials. They do the renal trials because they're relatively easy to do. You've got nice hard endpoints. You've got a creatinine, you've got a protein creatinine ratio, you've got a biopsy, nice, hard, simple things. The tougher part is accepting that at least 60, if not 70% of lupus patients don't have biopsy-proven nephritis. So you've got to have trials of non-renal lupus. And then there, as everybody knows, it's a lot trickier. So we have these rather complex ways of trying to capture these things. But in the main, patients are brought into these trials with skin problems and joint problems. And if they've got CNS disease, for example, no way are they allowed anywhere near a trial. And so it's very hard to be sure until much further down the road. It's, I think, quite interesting that with belimumab, it's now becoming clear that belimumab does help a number of other features beyond the joint and skin, which is where it started. But no, the answer to your question is, I don't think, answerable at the moment. We need to do, as Ron said, another phase 3 trial before we can convince the American authorities, the FDA, to approve it. So we're a long way from knowing that. And I feel that I'm in a very analogous situation to the situation we have with our rheumatoid arthritis patients, where we now have 5 approved different kinds of approaches. They're successful, the drugs are affordable, but in which sequence should we be using those any of those 5 drugs? Who the hell knows? I mean, we don't know. We know, for example, if you don't have rheumatoid factor, then it probably isn't sensible to start with rituximab, but otherwise, certainly in the UK, it's done on a purely historical basis. Because TNF-alpha drugs were approved back in 1996 or whatever it was, we go for those first of all. That's more or less mandated by NICE. But we know that at least 25 to 30% of patients, it's not going to work. So it's a trial and error thing. And I'm afraid we may well get to the same situation with lupus. Perhaps in 5 years' time, we'll have a number of the drugs that Ron was talking about will be approved, but we could well be in the same position of having 5 drugs which have been shown to work in phase 3, but what sequence? Which one should we go for first? I fear that we could end up in the same kind of situation.
So, Raquel, your question, I think, was also if there are certain patients for whom these new drugs will be particularly effective, right?
Yes.
And I think that's such an important question. And we have not done a terribly good job at figuring this out for most of our drugs. Yes. And I think phase 3 trials typically also don't help so much because they have to be so big that basically all patients are asked to please participate. And then you have 800 patients in a trial. And at the end of the trial, the drug is better than placebo, which is fine, but you still are often not able to tell for which patient it was outstandingly effective.
Yes.
And so we have to use the small clues that we have. And I'd like to digress a little bit to tell you what I think for this drug, which we were talking about, dapirolizumab pegol,
yes.
which, by the way, David, I liked your story, and I was not at that meeting, but I heard all these stories about it, which was really amazing.
It was amazing.
And it's just, but for our listeners, I think it's important to realize that that was a drug that indeed was a precursor with the FC portion. And the current molecule does not have the FC portion, so it should not have that particular very dramatic side effect. But what I thought was really interesting was a study done with another molecule called dazodalibep, made by a different company, tested in Sjogren's. And it was a successful trial that was published in Nature Medicine also in the past year. And a very interesting report because what it did was in part what you would expect, which is that they took patients with Sjogren's who had a lot of immunological activity. And then they gave them the drug, and those patients did better than the ones who got the placebo. But then they also took another group of patients in the same trial. And those were patients who did not have so much immunological activity, but they were feeling tired, they were feeling achy, they had cognitive difficulties, and they were not able to function very well. And of course, we recognize this from lupus as well. And some have even called it type 2 lupus symptoms. And so this is a real problem. And in the trial that I just referred to in Sjogren's, they took those patients, gave them the drug, dazodalibep, and it actually worked. And I would not have predicted that. I would have said, forget it, because those are not autoimmune manifestations. But it turns out they might actually be. And the mechanism of that drug was the same as what we were just talking about, the CD40 ligand interaction, the co-stimulatory action. It's sort of small print immunology textbook, but it basically boils down to another way to dampening down the immune response. And if it could be true that for patients where the symptoms are mostly the subjective manifestations, not feeling well, feeling tired, having aches and pains everywhere, not sleeping well, not being able to concentrate. And if this mechanism could help those patients, then we have reached a real big milestone. Now, I don't know if that's the case. And I sometimes I'm asked by companies to give them advice. So you can bet your bottom dollar that I gave the advice to the company making dapirolizumab to please investigate this question, because we so badly need a drug like that for lupus. But I'm hopeful, because there seems to be something that gives us reason for optimism.
Thank you so much, Ronald. Can we talk a little bit about deucravacitinib? And this drug is a TYK inhibitor, as Ronald already said, that is part of the JAK-STAT stimulation, and it's already in use, in clinical use for psoriasis. And it's on the phase 2 trials, it has good results in lupus. And David, this is an oral synthetic agent. And okay, no phase 3 yet, but how do you feel about the use of an oral drug, synthetic, biologic-like, what do you feel about its use if it comes to the phase 3 trials?
Okay, so I think you perhaps could see this from the patient's point of view. And I think patients, often, some patients I have anyway, much prefer taking things by mouth and having to inject themselves, or even having to come into the hospital perhaps once a month or once every couple of weeks for an infusion. So I think from the patient's point of view, having an oral something like steroids and whatever, then I think that's quite a nice thing to offer the patients. In the end, though, my feeling is that it's a critical question as to whether or not it works. I think patients don't mind, by and large, if the drug is going to be very successful, if it's going to get rid of their fatigue, their joint pain, their whatever. Mm-hmm. I think they're prepared to put up with it. But I think if it also happens to be something that you could take as a tablet, then obviously that's an advantage. So I think that's good. I think the fact that it's been used in another disease from the safety aspect gives us a lot of information and reassuring information, because with a lot of the drugs that we've been talking about, these drugs are genuinely new drugs and new to lupus patients. So patients often ask me, well, is it safe? So the fact that I can now say, well, look, a lot of patients who've been given this drug happen to have another disease, psoriasis, but we can be very reassuring, because based on hundreds, if not thousands of patients, we can tell you that the chances of getting a skin rash are 2% or whatever the figures are. So from that point of view, it's useful to have that information. In the end, I think nice for the patients to have an option to take it by mouth if they really don't like injections. But in the end, the key question is, does it work? That's the most important question.
Yes.
But then on that particular drug is where I meant that the phase 2 trial was actually quite a big phase 2 trial, a large trial with lots of patients. So it actually gave us quite a bit of confidence. I'm a member of the steering committee for the phase 3 trial, so that's my disclosure. But I do think there are two very strong points for deucravacitinib, and you already mentioned them, Raquel. It's an oral drug, and also the very vast experience in psoriasis, where thousands, if not tens of thousands of patients have now already been treated, and it seems to be tolerated well with a favorable benefit-risk profile. Having said all that, there are some weaknesses, one being that the dosing is a little bit unclear. The dosing
Yes.
for psoriasis is not the dosing that's being tested for lupus. So there's a little bit of confusion around dosages. But what's interesting about it is the mechanism, because it's the JAK-STAT pathways basically it's interfering with cytokines, because the cytokines need to
Yes.
signal through JAK-STAT. Which cytokines? Well, with this particular one, which blocks TYK2, it's actually the interferons type 1.
Yes.
And then also IL-12 and IL-23. Now, but type 1 interferon, we already know from experience with anifrolumab and some other drugs in earlier phase trials that pathway is a target, is a suitable target for therapies. IL-12/23 was actually tested by a trial that looked promising, as David earlier alluded to, looked promising but failed in phase 3. Whether that's very important in lupus remains a little bit unclear. But I do think that with deucravacitinib, again, we have a very specific mechanism that could very well play a big role in some patients with lupus for sure. And it's adding to a very exciting year in 2025 with new results from the phase 3 program.
Thank you. And can we just, I have one question for you about the other drug, ianalumab. It's a fully humanized monoclonal antibody that has dual action. It depletes B cells by cytotoxic antibody-dependent cellular cytotoxicity, and also block the BAF. So it would be a new generation combination of rituximab and belimumab, for example. So how do you feel about it? Do you think in terms of not only safety, but if we empathize about this mechanism, Ronald, how do you feel about this drug?
Well, so the first results certainly look very good, and I agree with you that it's a bit challenging to the mind because we're both depleting and blocking activation. And the question is, in which order would you want to do those things, and does it help to do both with the same drug? And I don't think we have the answers to those questions. So there's a lot of interest now in B-cell therapies. I'm sure we're going to talk also about more profound ways of B-cell depletion in a moment. But for now, I would say that if ianalumab does indeed have the efficacy that is intended in the phase 3 trial program, then I think we will have to make very detailed and thoughtful comparisons between the mechanisms of depletion, for example, rituximab and obinutuzumab, with blockade only of the cytokines involved with belimumab, but also, as you mentioned earlier, telitacicept would be doing that, including APRIL, and then with ianalumab that combines those two mechanisms. And we're still unclear about the pronunciation. So some say ianalumab, and that's the easiest one, but others try to say ianalumab, and I tried that just now and I failed.
David, you have experience with rituximab, and more recently also with the protocols of sequential therapy with rituximab and belimumab. So do you have this same feeling that this would help? How do you feel about it?
All right, so I can't resist telling you what it's not actually a story. It's a data-driven observation. At the ACR this year, there was a paper which came out of Japan reporting on a survey, I think, of 117 patients with lupus nephritis treated by rituximab. What amused me a little bit was the implication that this was a new drug, a new development. And I felt like I said, well, hang on a minute, I'm sure I've been using it for the last 25 years. But I think that I remember, and I'm sorry, I am going back in history, as a medical student, being very struck by a major difference between the oncologists, even in those days long ago, and the rheumatologists. The oncologists were very gung-ho. We'll use 3 or 4 drugs. We can try and get our patients better. It'll take lots of drugs. The rheumatologists were very, very nice people. We'll give one drug, we'll give it for 3 months. If it works, that's nice. We'll carry on. If it's not so good, we'll stop that one drug and we'll repeat it with another one drug. And it really wasn't until the Odell paper came out in 1996, which showed that triple therapy for rheumatoid, methotrexate, cefazolazine, hydroxychloroquine, was good. That really the idea of combinations really began to sort of shine. And so the idea that you can combine biologic drugs, whereas it's somewhat expensive, you might say, but there's no reason not to try to think about it because it could be very helpful. And the observation that that this might be a good way to go came from a piece of work that was done by Michael Ehrenstein and myself, working with a fantastic graduate student who's now a consultant up in Newcastle, working with John Isaacs, Lucy, her name is. And what we observed was that there were one or two patients in our group where we gave them rituximab and it knocked the DNA binding down, and then there was a kind of an overproduction. So the DNA binding went down, then it went up and down when we retreated, and went even higher. And we wondered what that was due to, and we were able to show, Lucy was able to show, that it was very much linked to BAF levels, which we were able to work up in the lab. So Michael then suggested, well, in that case, why don't we combine the two drugs, give rituximab followed by Benlysta? And there have now been, I think, 4 attempts, 3 quite serious trials, and a quick look-see, which was done in Holland, actually. And of those 3 trials, the problem is the results have been conflicting. So the best trial happened to be the one which Michael led on, in which we took 52 patients, and they all got rituximab. Half of them got Benlysta, half of them didn't. And we showed that not only was the primary endpoint, which was serological, was met, but also in terms of the numbers of flares, that was strikingly and highly statistically significantly reduced if you got rituximab with the Benlysta. I think we had 3 flares in that group, and if you just had Ritux followed by placebo, there were 10 flares in the course of a year's follow-up. So that was pretty interesting, I thought. There's been a trial done in the States looking principally at lupus nephritis, the Calibrate trial, but that's really a safety study. It wasn't powered to look at clinical benefits, but they did look, and they didn't really find very much. And then the other study is Bliss Believe, which was the biggest of the studies. That was a mix of mostly, I think, non-renal patients, but some renal patients as well. And that didn't show any clinical benefit. But in that situation, they did the opposite, that everybody got Benlysta, then half the patients got rituximab. So maybe it's the sequence that's important. Perhaps you have to give the Ritux first, then the Benlysta. I don't know. I think the jury's still out about this, but I think rheumatologists need to take a leaf out of the oncologist's book and not be afraid to use more than one drug, even at the same time, or close to the same time.
Thank you. There's another drug that had good results this past year, 2024, that personally, I feel a little bit of chills about it because of the safety in myeloma with other drugs. So daratumumab, that was imported, an anti-CD35 monoclonal antibody that was imported for the treatment of multiple myeloma. Of course, in multiple myeloma, it is used with many other drugs. And this was a phase 2 open label trial that was presented in EULAR. So, David, how do you think that this drug is different from the others? And if it comes to a good phase 3 efficacy trial, how do you picture this drug on the treatment of lupus, taking into account every other drugs that we have on the pipeline?
Daratumumab is an anti-CD38. The study that I saw, and Ron may know more about this, was I picked a very small number of patients, maybe 10 patients or something like that. The data that I saw anyway, it looked interesting in that the DNA binding fell quite substantially. The SLEDAI fell from 12 to 4 points. The CLASI fell. SRI4 was met in virtually all of the patients. The worry was that the IgG levels in these patients fell quite dramatically from about 12 to 6.2 from memory. So I think you would approach this one rather cautiously, I think. And I think clearly you would need to measure the immunoglobulin levels pretty frequently in this trial to be sure you're not overdoing it. Maybe it's a dose thing. Maybe they have to sort of cut back on the dose a little bit, whereby they could get the effect without quite the side effect. So I think I'm optical. I'm very much on the cautious side with this one.
Ronald, do you have any comment?
Yeah, no, I agree that this is mostly the toxicity that is going to limit it.
Yes, thank you. So, taking in account every other drug that we talked about and all other that may come up, how do you think that these drugs would add anything different from what we have now, belimumab or anifrolumab, that may lead some hope, and besides what you said, Ronald, about the anti-CD40 ligand treatment?
Well, can I jump in there? Because
Okay.
you touched on the rituximab question and where it's kind of going. So the problem with rituximab is a relatively simple one. It's 20% mouse protein. That's the problem. It started life as a fully mouse protein. It was humanized, but 20% is mouse protein. I've treated just over 200 lupus patients with rituximab now, and the problem is that about 1 in 6 of these patients will develop an allergic response, and quite a serious one on occasions, and an almost similar number, not quite so high, but an almost similar number will also drop their IgG levels. So what we need and what we now have is a fully humanized anti-CD20, where you would expect, certainly in terms of allergic responses, that number would drop quite significantly. And guess what? We have it, obinutuzumab. We had ofatumumab, which didn't quite make it because of side effects, but obinutuzumab does seem to be better. The trial that I alluded to before, published at the end of September in phase 3, lupus nephritis looked very good. And I think there are realistic hopes this drug is going to get approved within the next 12 months by the FDA, and hopefully that drug will be taken nice, it will get nice approval, we can actually use it. So here's an example of a route which I think most people would accept does work. It's not a cure for patients, but it certainly does improves it. And the BSR's biologics register looked at 1,100 lupus patients and has published a lot of data about that. So it's not just me saying it, it's one of the people saying it, but this is the whole BioLab group, 20 centers contributing to the data. So if we've got something which is safer and is likely to be as good, it may in fact even be better. My colleague Venkat Reddy, for his PhD thesis, looked at the capacity of obinutuzumab compared to rituximab and some other CD20 depleting agents. And so the obinutuzumab was particularly good at getting rid of the CD20 positive B cells, more effective than rituximab actually. So it won't be as good as CAR T cell therapy, but which gets thought into the tissues, gets rid of the tissue, gets into the tissue to get rid of the B cells which carry the CD20 marker in the tissues. But certainly with obinutuzumab, I think there is going to be a good future for that, because I wouldn't be at all surprised if it replaced rituximab completely in the next 5 years. That would not surprise me.
Ronald, moving to obinutuzumab. Yes.
Sorry?
Moving to obinutuzumab. The trials were for lupus nephritis patients, not global systemic lupus erythematosus. But despite not being approved in most of the countries, rituximab for on-label treatment of lupus, many of us do have experience. So do you think that if obinutuzumab is going to be approved for lupus nephritis, we are going to be able to use it also outside nephritis? What do you think about this?
Well, this ties into so many aspects. So the first is, do you think it would even work in patients with lupus but not nephritis? And I think that we have to leverage the fact that we understand a little bit about the mechanism, and that the mechanism has to do with B cells, and B cells have to do with autoantibodies. So I think in patients with lots of autoantibodies, and especially the ones that are believed to have pathogenic significance, then it still stands to reason that a drug such as obinutuzumab would work. And so then we would like to try it if the patient has failed other available therapies. They don't have lupus nephritis, but they do have bad lupus. That seems to make sense. And then, of course, the question is, will it be paid for? Will the regulators or the local authorities, the national authorities, will they allow it? So, and let's not forget that in the development, the decision to develop a drug for lupus in general or for lupus nephritis, that's not a very scientific decision. The companies sit there with all their flow charts and their Excel sheets, and then they make a decision that's also very much a business decision. So the fact that it's approved for lupus nephritis does not by itself prove that it's not effective for other kinds of autoimmune diseases. It's just that's what we have right now. And then we have to cautiously extrapolate from there.
So, and of course, that there are going to be differences between countries of the paying of these kind of drugs. Okay, thank you so much. And do you have anything to add on? David, you are trying to make a point about the previous. Okay.
Well, I just want to highlight that exact point that you know we're talking through the prism of the lens related to the countries in which we work, but you will recall a fantastic talk that Sandra Navarro gave at the Lupus Academy this year, which I thought was a very strong reminder that there is a big world out there where the rules are very different and the availabilities are strikingly different. And she looked at the availability of biologic drugs, comparing the UK, States, the Philippines, and Germany. And it is very remarkable, actually. In the States, for example, I've heard that it's very easy to get Benlysta, it's very easy to get voclosporin, it's very easy to get anifrolumab, and yet they can't really easily get rituximab because it failed its endpoints in those trials 15 years ago. In the UK, we can get Benlysta, we can get voclosporin, we can't get anifrolumab because the company, AstraZeneca, have thus far not taken it for a serious discussion to NICE, and so it's not approved by NICE. So I know of this drug which clearly helps a lot of patients with lupus rashes. I mean, I can't use it, it's so annoying. But in the Philippines, they can't get Benlysta, they can't get voclosporin, they can't get anifrolumab. They can use a biosimilar for rituximab, and they use it substantially. So, depending on which part of the world you're in, and depending on the rules and customs, so the difference in availability is absolutely remarkable. And I suspect as newer drugs are approved in the States and in Europe, I'm afraid the same issue is going to continue. And this will particularly true in Africa, where we know that unfortunately the wealth of the individual nation states is such that many drugs, even relatively widely available drugs in the rest of the world, are not easily available. And I remember years and years ago going to a Pan-African conference around the time that the TNF-alpha blocking drugs had really established themselves, and we were talking about whether or not TNF-alpha blocking drugs would be great for rheumatoid and psoriatic arthritis. And they had an ethicist there who gave a fantastic talk. And she laughed at us. She said, you guys are talking about these very expensive drugs. What you've got to understand is that in Africa, there are 10 major wars going on. If you think the economies of these countries are going to sustain the use of infliximab and the like, you must be joking. It's never going to happen. And I'm afraid, there are parts of the world where, sadly, very effective drugs, and we know that whatever the older story was, lupus is pretty common in Africa. Drugs which are very effective for lupus and lupus nephritis are not available. It's not available very easily, and that's a real tragedy.
I just wanted to add a note for those who are listening to us and haven't heard yet the podcast where we interview Sandra Navarra about treating lupus in middle to low income. You can just go 2 episodes before this, 1 or 2 episodes, and you can listen to our interview where she explains all these. And actually, middle to low income countries have, by statistical analysis, 80 to 85% of the lupus around the world. So it's really, if you haven't heard yet, please go back and go to hear that. Coming back to our discussion, do you have, both of you, anything that in 2024 gave us new insight about the use of belimumab or anifrolumab? Now they are being used on real-world data. David, do you have anything to highlight?
Well, I think for me, the most important data that's been coming out with regard to belimumab is, first of all, to emphasize its safety. This does seem to be genuinely a very safe drug, so I think that's good to know. It is being used and is used with approval. In fact, we may come on to this later. The recent ACR recommendations for the treatment of lupus nephritis now recommend Benlysta at a much earlier stage than perhaps was the case. So we know that it works well enough anyway for some patients with lupus nephritis, so that's good. And I think gradually we're beginning to see its use in a whole range of other lupus sets of features. So I think that's for me is the big messages for that drug.
Ronald, do you have anything to add? Or thinking about anifrolumab, was there any data that was presented in 2024 that highlighted some other point of the use of anifrolumab?
I think we're right now really at the learning curve stage where we are, as rheumatologists and other specialists, using anifrolumab and then also seeing with our own eyes what was already shown in the clinical trials, that there's a very good efficacy. In some patients, even dramatic efficacy, and others perhaps not so. And so we have to just find the right place to use it in our armamentarium. With belimumab, of course, we are actually past that point because we've used it for long enough that we feel very confident, as David said, very safe. And We know that the efficacy, and we also recognize limitations. So it's being used, both drugs are being used, but with slightly different, I think, experiences in terms of how much we feel confident and comfortable using them.
Let's now move on to the big issue that you are pointing out since the beginning, CAR T cell therapy, and including bispecifics. So we are all excited about this, David, and you have been really excited about it. We have discussed it before. Can you comment how these kind of strategies will be applied to real patients on our clinical practice? How do you feel that you are going to use CAR T?
Okay, so
Therapy.
I can tell you a little bit of a story that's ongoing. So the work by Georg Schett and his colleagues is absolutely fascinating. I mean, it really is. The notion that you could treat patients with a form of treatment, and within 3 months they're off all the lupus drugs, and 1 to 4 years later they're still off those drugs, and importantly the lupus antibodies haven't come back. That's pretty sensational stuff. The problem is at 350,000 euros per patient, which I'm told is what it costs in Germany, that's going to be pretty off-putting. And I can just see what NICE is going to say to that. So the issue then comes to which sort of patients. Now, Georg Schett, who is a very approachable sort of guy, has said to me, look, we were very careful about the patients that we chose. They tended to be younger. The duration of disease in those patients, those 8 patients, famous 8 patients, is I think 3 years. We have got 5 patients into a CAR T-cell trial at University College London. We've got some very good oncologists at the hospital, and they've been very supportive of this. And the very first patient that I used CAR T-cell therapy for was completely unlike the Georg Schett patient. She was about 50 years old. She'd had a disease for 25 to 30 years, but she had active nephritis, which interestingly had come on relatively late in her disease course. She also had an overlap with APS. She also had an overlap with myositis. And you could say, well, how convenient, because CAR T-cells treats myositis and lupus, so she could get a benefit from both. But it's been very, very interesting. And she's now about 6, 7, 8 weeks out of the treatment. And she's already, I've seen her in the clinic, she said to me, the arthritis, which has bugged me for the last 25 years, has gone. It's not there anymore. And this is pretty exciting stuff. So I think certainly the limitations are simple. Financial, that's number one. Number two, you've got to have a center which has got great expertise in oncology. These patients come into hospital, they spend 1 to 2 weeks there. You've got to have the oncological expertise, and unfortunately my hospital, the guys have got that. So it's in the UK, I would estimate that only perhaps 6 to 10 centers in the whole of the UK would have the capacity to be able to give this. What we need, these patients are all being treated with autologous methods. What we need is something more off the shelf, and that's allogeneic, and that's going to come later. But there are trials now going on, monitoring reports, in addition to the Georg Schett work that was seen at ACR. Ron may want to comment on those. Again, looks very interesting. But I think if it's going to be used more widely, that the period of time in hospital has got to be shortened somehow. Because that's where the costs tend to come. We're going to have to choose the patients at the moment anyway pretty carefully. I think it'll be restricted to patients where most other things have failed. And that's why I think it's unlikely in the end, unless there are major changes in which it can be given, to be the answer for everybody. And that's where the bispecific engagers, monoclonals which block both or are linked to both T cells and to B cells, may have a much bigger part to play. And cost obviously will come in there too, but obviously if you can give those as an outpatient, it's going to be so much cheaper. So very exciting, but with caveats, I would say.
Ronald, do you have any
what can I add?
experience?
So the first thing, so the first thing to recognize is that CAR T cells, the technological development, the molecular machinery behind it is awesome. It's fantastic what people can do these days, and it's been really something that's been developed over 15 years. And the level of sophistication this really is rocket science. But in the end, what you get is B cell depletion, because that's what we're talking about now. Our CAR T cells directed against CD19, they deplete B cells. And then the question is, what can you expect from B cells? Now, the reports from Erlangen are limited in size. It's a number of patients. The total number of patients treated is now maybe around 20 or so. Formal reporting has been done on 15, perhaps. Some of them had lupus, others other things. And there's two things, and these have to be kept strictly separated. So one thing is that basically what they're saying is all patients responded. So after 3 months, all patients were doing a lot better than before. Now that's good, and we're happy for the patients, but it's not sensational. But they also reported something else, and that is that 2 years later, some of these patients were doing fine. They did not need any treatments anymore. And their autoreactivity, their autoantibodies had not come back. Now that's true for a very small number, even smaller number of patients than what I said initially. This has now been shown for a handful, literally, of patients. But that has opened this speculation that maybe depleting B cells to this very profound level does not only treat the patient temporarily, but effectuates a long-standing change, a long-term modification of the autoimmune process, an immune reset, an immune reconstitution. There's all kinds of terminology has been used, and David, you already alluded to. It has been called by some people a long-lasting treatment-free remission. But of course, what we're thinking in the back of our head is it maybe, has the patient been cured of their lupus?
Mm.
The problem with that is that, okay, number one, is it even true? And number two, if it is true, how can you even prove it? And what is important to recognize is that this is not unique. This has happened before. I think all of us who practice rheumatology and see patients with lupus know that every once in a while, we go to our outpatient clinic and the patient comes by and we look at them and they say, oh yeah, you look familiar. Yeah, don't you remember me, doctor? I was here 5 years ago and I had lupus and I was in a bad way and you gave me various treatments. But I didn't come back because then I was doing so well and I was able to stop with my treatments and everything was fine. My blood tests look good. And that's why I haven't been back. And I just wanted to tell you this. So this sometimes happens, and it mostly happens to a certain patient profile, but we do not know exactly when this happens. And it certainly doesn't happen often enough to bank on it. We cannot use this as a reason to say to patients, oh yeah, you should be very happy, but it can happen. And it's been reported in the past with other invasive therapies. It has been reported with autologous stem cell transplantation. It has been reported with high-dose cyclophosphamide. There have been some other variations on this theme. The problem is that we cannot really predict for which patient this will happen. Now, with CAR T cells, it has happened now with a few patients. It may very well start happening with more patients, but it's not likely to start happening with 100% of the patients who are treated with CAR T cells. So we need to find out, is it something that we can promise the patient that they have a 50% chance or an 80% chance or something else, and that will make a huge difference. Because I think if you tell the patient you have 50-50 odds of getting rid of this disease, I think many patients will be very interested. If it is higher than that, they will definitely want it. If it's less, if we tell them that, well, there's that chance, but it's 1 in 5, and you also have to deal with a lot of side effects and risks, and then there's the cost issue, which let's not even talk about that. Then I think it gets to be a much more nuanced kind of discussion. So we're going to have to find out much more. There's lots of trials now happening with CAR T cells. In addition, like David, what you were already saying, there's other variants, other B cell depleting therapies that are achieving the same, but in maybe easier ways with bispecific monoclonal T cell engagers. There's the allogeneic CAR T cells and CAR NK cells that are being developed that may also achieve the same thing at reduced cost. So I think there's lots of very, very exciting developments, but we have to keep straight what we do know and what we still do not know, and that's going to make a big difference.
Raquel, can I add, and I've been to know everyone's had some experience.
Yes, of course.
We've had a kind of Goldilocks experience in these trying to recruit patients for these trials, in the sense that to get patients into these CAR T cell trials, they can't be too mild and they can't be too severe. They've got to be bang in the middle, and they've got to have a renal biopsy done within the previous sort of 3 to 6 months. And as a consequence, the numbers of patients we have available to enter into the studies has been reduced. And several of the patients are very cautious, actually. I've had several patients saying, oh, it's very new treatment. I'm not quite sure about, side effect profiles. You can't really tell me what's going to happen. And they've turned us down. So although we've got 5 patients into a study that we need to get 6 patients, we've found them, but it's been much harder work than I thought. I don't know whether, Ron, have you had that experience?
We haven't started patients on this kind of treatment yet in Amsterdam. We're planning on doing it, of course, but so far not. I do think that the formal trials, almost by necessity, will have very strict criteria in both directions, making the recruitment really an issue. And also the real question, if all of these trials can be done sort of at the same time, even if it's global, even if it's worldwide. But will it be possible to run so many trials targeting the same patient population? It's a real issue.
Can I raise an issue about this? Remembering how this technology started mainly in lymphoma patients, and this engineering was targeting the lymphoma cells. Hematologists, oncologists were able to see on the next weeks or months if there was a molecular remission or if the lymphoma had came back. And in lupus, we don't have this way of measuring molecular remission. So for both of you, how do you think we can move forward to check the molecular remission in lupus?
Well, I would have to say that what our colleagues in Germany have done so far is right on spot, because they've analyzed the B cells and the B cell repertoire, and they've looked at autoantibodies. And if you see all the B cells, or you see the B cell compartment being repopulated, but there's no autoreactivity, that gives you pretty good confidence. The question is, will it be sustained?
Yes.
It's great to see this after 6 months. It's now been seen in some patients indeed for 2 years, but you never know why those B cells, those autoreactive B cells started in the first place. Is it just because there was a clone, or is there something in the microenvironment of the lymph nodes or the spleen or somewhere that's driving the emergence of these autoreactive B cells? And if the latter, then it might still come back even after a long time.
Thank you. So lastly, and in the few words, Ronald, what do you expect from 2025 in lupus?
Oh, I expect great things. I think what will happen is there's going to be some of the large trials that we've been talking about will be reporting out, and I am optimistic. I think some will report out with positive results. The regulatory authorities will be studying some dossiers and files of drugs that may then end up being approved. And we will also learn a lot more about the development. We just were talking about the very intensive B cell depletion with CAR T cells.
David?
Yeah, no, I agree. I absolutely agree with all of that. And I would say I am reasonably confident that we'll see approval by the FDA of obinutuzumab. And although it's clearly going to be a lot more expensive than the rituximab biosimilars, which are very cheap, certainly in the UK, you could treat patients now with these biosimilars for about the same cost of mycophenolate. So it's become very affordable now, and that won't be the case with obinutuzumab. But let's once it gets approval, I think it will be much more widely used, and it will answer the question that you posed to us: will it help non-renal patients? And I suspect we'll start to get those answers over the next year or two.
Thank you so much, David and Ronald. Thank you for joining me today and sharing these insights from data of 2024. To our listeners, we hope this discussion have helped you gain more of an understanding of lupus and developments throughout 2024 and even 2025. Who knows? Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next month for more discussion, key issues in the management of lupus.